So at this point, I'm going to turn it over to Sue Fosnight to begin the didactics.
Found that about 30 to 50% of these medication events are really thought to basically be classified as a risk for serious morbidity. So just to make sure we're, again, all on the same page, an adverse medication event is not only a medication error, but it's also an adverse effect or a medication failure. But we do know that a lot of our older patients, that they are more likely to have these issues, and that 12 to 20% isn't specific for older patients. So we're probably talking about even a higher percentage in those older patients. We do know also, like I said, our older patients are very prone to have these medication errors or events. And the reasons for that are they often need more complicated care, requires more medications. So more medications, more likelihood that there'll be one of these issues. I find that many of our older patients, especially when they're first getting into the hospital or getting out of the hospital, they're less likely to be able to advocate for themselves. So for instance, if there is a medication error on a younger patient where we started something maybe that has been stopped, the nurse would bring that medication to the patient and the patient would say, no, I don't take that anymore. I don't often see that happen with our older patients like it does with our younger patients. And then the other thing, like I said, often our older patients will have more serious effects because they just have less physiological reserves. So an adverse medication activity event or effect that would happen to you that you might barely notice might cause an older patient a lot of issues just because, again, there's less physiological reserves for the body to right itself quickly. We do know in patients greater than 65 years old, up to 23% of readmissions are due to medication-related problems. So about one out of every 4 or 5 readmissions do have a medication issue in our older patients. So when we see a medication history being done, so compared to what the patient will originally just tell us when we ask, what medications do you take at home? What's the average number of errors that we find on a medication history? And if you guys want to just put that into the chat, that would be great. Okay, I'm seeing people that have some experience with this, and 3 is the correct number. So that is the average number. I know personally we have done a QI project with this, and I think our record was 12, but 3 is what we would see on an average. We saw that here at SUMA when we did this, but we also, that has been reported in the literature to be, the average number is 3. Of those 3, all of those are not serious issues. And what the literature is telling us and what we found in our study as well is usually about 1 could have some potential to cause some harm to the patient or to increase their length of stay for one reason or the other. So although 3 is not the total amount of serious ones, we do still see about 1 per patient. Let me see if I can, for some reason, I don't want to, there we go. So what are the actual hazards of a poor medication history and then the reconciliation that goes along with that? Really, the medication history is very critical. So if you don't have accurate medication history, then obviously you're going to base your decisions on a list that is not correct, on not the information that's not correct. So we always say garbage in equals garbage out. For some reason, I'm having trouble getting my slide to advance. Let me move things around here a little bit and see if that helps. There we go. So some of the things that can happen and that happen quite often is starting a medication that has been stopped, not starting a medication that the patient is on. So duplicate therapy once the patient gets back home. So perhaps we start a different medication for the patient. We didn't know that they were taking carvedilol, and we start metoprolol while they're in the hospital, and they take both when they go home. And then incorrectly optimizing medication. So if we don't know what the patient is already on, then that makes it hard for us to optimize their current medication. That starting a medication that has been stopped is the issue. Somebody has actually studied that and shown that when we do that, about 20% of the time, that's going to cause patient harm. So if a patient has actually already stopped a medication and that gets restarted by accident, that's probably the biggest issue we can find. I do have to say, though, that not starting a medication that the patient is on at home, I have seen that also causes patients to go into AFib and have other problems as well. So none of these results are really good for our patients. And as you would suspect, we've already talked about, they result in medication errors, increased length of stay, and definitely an increase in morbidity. Now, when we're talking about our older patients and what's different about our older patients, I think a lot of our older patients that come into the hospital are in an acute situation, and oftentimes they do have some delirium going on. And in those cases, it's very hard to get from them their accurate medication list. So we are trying to then turn to others to figure that out. And I know our older patients without delirium, they're often kind of anxious because they came into the hospital, oftentimes leave something off or forget that they're not taking something. So lots of errors that I think are more in our older adults. So now COVID enters, and we have to do more of this by telehealth than we have ever done before. So what are our tools? Really nothing real fancy. If we have the opportunity to have tablets, that would be wonderful, to actually have a tablet to speak with the patient. Unfortunately, I haven't had that many times. I have occasionally been able to speak with the patient via a tablet. We also have iPhones. So many of our older patients do have iPhones, and certainly that is a place that we can invite them to a meeting and do our interview face-to-face, but not really face-to-face. But oftentimes we are stuck with a telephone interview, and I would say most of the times that's how we are doing those interviews, where we can't actually go in and see the patient. So what are some tips to do when we are using this type of method? The first one is to start with a list. You want to make sure that you have a list, some idea of what that patient is taking before you get started. Now, you may get that list from the electronic health record. You can get it from the pharmacies, especially if they are getting compliance packaging such as DocuDose, then we definitely want to make sure we know what they are being sent. There are some prescription fill list services that are out there. Exchange Point is the one that is the most common. And I have used Exchange Point. The biggest issue with Exchange Point that I have found is they're going to list everything that has been filled. So you also want to make sure that the patient's actually taking them. So they do list meds that have been filled but never picked up. So as we're trying to gather a medication history, one of the things that we want to keep in mind is, when was that medication last filled? What was the supply? And then if we're deciding to see if they're really taking it or not, we need to take into account the time that they've spent in the facility between the time it was filled and now, because oftentimes it looks like they're not taking it, but they've been in maybe in the facility for a while, so that's why. I don't know why I'm having some trouble with this. Here we go. All right, so when you're speaking to the patient, important to establish a relationship with the patient. So even though you're over the phone, I do think it's very important to make sure they understand who you're talking to, and if you have something that you can bring up to kind of start that relationship, I think it's an important thing to do. So the next step would be to explain why you are calling on the phone instead of speaking in person. So oftentimes I want to make sure that they're not afraid to give me information. A lot of our older patients, when you're talking to them, not face-to-face, that they'll be worried that this is a scam call. So you want to mention who you're working with. So if they're seeing somebody else on your team also, then making sure that they understand that I'm working with that person and that's why I'm calling. So be patient, make sure you speak slowly and clearly. And it does certainly take a little bit more time when you're doing this by phone. One of the first things that I want to ask is there anyone that helps you with your medications? I ask this whether I am doing it in person or not, but especially on the phone, I think it's very important. We don't want to get too far into this if they're not really the person that handles the medications. And I also want to know pretty quickly, where do they fill their medications? So I will have the names of the pharmacies that I had on their list, but they may have gone to a different pharmacy that hasn't gotten into the electronic health record. So making sure that we know all the places that they fill their medications. And the last thing I would say about this is that we want to make sure we ask the most important questions first. So we have an older patient that's on the phone that's probably not feeling very well. And oftentimes they are going to get a little bit impatient. So I want to make sure before they get impatient that I got the information that's the most important for me to get. Like I said, we want to make sure we're interviewing the correct person. The person who is actually involved with filling the medication box is an important person to talk, but the most important person is the person who's actually giving the medications to the patient. They're the one that's going to be able to tell you whether they're actually taking it or not. So finding out if it's a son, if it's a daughter, if it's a spouse, on who actually manages the medications, especially in our patients that are confused. When I am talking to one of these people, to whoever's managing the medications, I try to get them to tell me the name of the medication. So dividing the medications by disease states so that you can ask, I see you have COPD. What do you take for that? And that helps not only to for us to get accurate information, but it also helps to reinforce if they don't know what they take for that, then we can offer them what we have on our list and help to educate at the same time. And then if we have basically a disease state that doesn't have a medication, we want to be very careful to inquire about that. That might have been something they left off by accident. So we want to make sure that we ask about that as well. And then to remember to ask about what I call the forgotten medications. So medications that aren't actually right with the capsules or tablets are oftentimes left off. So we want to ask about OTCs, about herbals, about inhalers are very, very commonly left off, patches, and refrigerated meds oftentimes will not get included in the original medication list. Depends where these little boxes are, whether it goes. All right. So what can we do to decrease these transition errors? And I do think there are some things that we can do. So one thing would be to keep the electronic medical record up to date. And you might think that we're doing this, but we have to be very careful about the common things I see is just overlooking changes that might be made on the list. So on our electronic health record, maybe it says to take 1 tablet, but if you read the notes at some point, the physician changed it or the prescriber changed it to 2 tablets. So we just want to make sure we keep that up to date so that when the patient does come to the hospital, that it is accurate information. And then also when we tell a patient to stop the medication, be sure to take it off the medication list. And also, it's a good idea to call the pharmacy and cancel that prescription as well. There is a service that's being done in other states. It's called Cancel RX, which allows you to send a cancellation of a prescription electronically. And I think it would be good for us to advocate that we get that in Ohio as well. We want to advocate for all healthcare providers to have access to their patients' EMRs. So anybody that might be involved with the patient, it would be wonderful if we had a universal EMR where everybody could see what the patient was prescribed, and that it all fed into one medication list. I know that's probably just a dream for a little bit, but I think it's good to advocate for that. And then to call in changes to compliance packaging services, that's a very important thing to do as well. So again, we want to keep the medications that the pharmacy is sending up to date. Also, making sure that the patient does have a accurate medication list that they keep in their wallet and also on their refrigerator. So every time that there is a patient visit, making sure that they are given a medication list with accurate medications. And encouraging our ER personnel who may actually give that list to get that list into the medical record as well. All right, so that's pretty much what I have on transitions. And then I had chosen to talk about non-adherence today as well. And I think non-adherence goes very well with transitions because that screening can be done when performing the medication history. So impact of non-adherence, I think this group very well knows that drugs don't work in patients who don't take them. Our former US Surgeon General had said that. And we know higher hospitalization rates, increased healthcare costs, poor medical outcomes are all related to non-adherence. What are some causes of non-adherence that you can think about in our older patients? Anybody, if you want to put it in the chat? Cost, memory issues, memory. So we have lots of, and all of those are correct. There's lots of different reasons. Access is another one, transportation issues. So we have lots of reasons why our older patients have problems with this. So these are actually what's in the literature of why anybody has problems with medication adherence, and that's complex therapies, expensive therapies, decreased patient memory, patient doesn't agree with therapy or diagnose, finances and health literacy are all considered issues. So this is a mnemonic that I basically have created to talk about ways that we can talk about medication adherence to a patient. This has not been validated, but I do find that it's helpful with not only just finding out that the patient's not adherent, but what is the underlying reason why the patient is not adherent. So C stands for cost. So asking an open-ended question to find out the cost. Oftentimes I say medications can be very expensive. How do you manage to pay for your medications? O is for organization. How do you remember to take your medications when they are due? Side effects. What side effects have you had for your medication? Transportation. How do you get your prescriptions from the pharmacy? Benefit of therapy. Which medications are helping you and which do you feel are not helping? You want to use these open-ended questions to try to create an environment where the patient's very willing to share with you if they're taking their meds or not. And this last question is a validated question. I know it must be difficult to take your medications regularly. How often have you missed a dose in the last week? So I always end with that question. So once you find this information, I have just listed on this slide some tools. So for costs, we have GoodRx, which can find lower cost medications at different places. NeedyMeds.com shows all the patient assistance forms. And most of our patients who are getting Medicare will qualify for patient assistance if they're not also getting a pension, if they are just getting Medicare. Formulary app is coverage app, is something, a fast way for us to find out if something's on the formulary or not. We can use pillboxes, compliance packaging, which definitely works better if they are on stable meds. There's calendars, there are reminder apps. So if the patient does have a smartphone, I like MMS Plus or PillMinder is my favorite one to put on somebody's phone. So to help them get on there. You don't have to put all the medications on there, but you need a medications for every time so that it is something that rings and reminds them to take the medication. And I've had good luck with that with patients. Side effects. So whether we can alternate the timing, alternate the medication, or sometimes we just have to treat the side effects. Transportation, a lot of patients depend on their family members to get medications, so they might wait till the weekend to start something new. There are a lot of different delivery services that are out there that we can direct our patients to. And benefit of therapy. So sometimes when I ask patients what is working for you and what is not working for you, they oftentimes say the things that are working for them are the symptom control meds, but the drugs that are used for like blood pressure, that those really don't do anything for them and they don't take them regularly. So making sure that they're educated about the importance of controlling those types of things. Same types of tools that I use for non-adherence is definitely, I'd rather do the interview in person, but having some type of an iPad, a smartphone, but oftentimes I'm stuck with the telephone. And again, you've seen these slides, the same type of thing applies. Adherence aids, we have lots of different things, pill boxes, we have electronic adherence boxes that I think many of you are familiar with, where you take if the patient doesn't take the medication during the time that's been allotted, it sweeps it away. And you can also have the option of notifying a family member or the physician that they're not taking that medication. We also have these newer items, which is an electronic adherence file, where it tells you the time that the medication was opened. I have on here one that just shows the last time it was opened, so they can tell if they remember whether they took it or not. But there's also a very similar type device where, again, it is connected electronically so that a family member would be notified if they did not open the medication at the right time. On the list here, I couldn't find a picture of it, but it is biodegradable sensors. I haven't ever seen these used, but these are basically sensors that are added to a medication so that you can actually know that the patient took the medication. So a lot of times that is one of the issues with adherence when we try to see what we can do is that we don't know if they actually put it in their mouth. This would notify you that, yes, they did take it or no, they did not. The smart inhalers, this is the device that you add onto the inhaler, and they have different designs for the different type of inhaler, and it notifies you every time the patient actually uses the inhaler. And the newest one is this connected injectable, where it basically goes over a pen, such as an insulin pen, that will help you know if the patient actually took their insulin as well. And I think the idea with these that notify somebody that they didn't take it is for somebody to be available to remind them to take these medications. So how do we remotely monitor for the outcomes from non-adherence? We've done home blood pressure monitoring for quite a few years. One caution is to make sure we check the meter in the technique that the patient is using to make sure we aren't being called in incorrect blood pressures. Home blood glucose checking, again, we've been doing that for quite a few years. And now we have the continuous glucose monitoring that has the advantage that you can have those values transferred to you electronically. We use home health nurses to monitor vitals and draw labs as well. And we do have the capability of using some smartwatches or devices, more and more apps that are coming out that can help beyond vitals, that look at whether a patient's having an arrhythmia or not, and various different types of data that will help us to make sure that the patient is adherent. Medtronic has a whole list of things that can be monitored through their pumps, or excuse me, through their devices that are usually implanted. So those also with a Medtronic device that is placed. So oftentimes people do have a Medtronic pump, or excuse me, device. They make pumps also, that's why I keep saying it, is Medtronic device. If they basically have a pacemaker, and you can get a lot of information from those. And there are some iHealth systems that they call, such as Livongo, Virta, Omada, that are out there that are mini robot type of things that certainly can provide a lot of information as well. So now that we have the vaccine, maybe we won't need to do this as much, but I think it still is important. And I don't think it's all going to go away. So I do think that our patients and ourselves have really gotten used to doing some of this rather than in person, doing it through telehealth. And I think there are some advantages in some situations to do that. So hopefully we will be able to soon be able to use our traditional methods for those who really do need them, but still use these other methods for those that don't need to be monitored or to be contacted in person. So that is what I have today.